behind.
Big flat.
All right. Let's go ahead and get started, everyone. Thank you for your time. Thanks for coming. Today is May 2nd, 2024, the Department of Internal Medicine Grand Rounds. We have about 5 sessions left. We end around June 13th, and then we will pick back up in September for those of you who are looking at your calendar. Today's session is sponsored by the Division of Nephrology. Dr. Ambreen Azhar is going to speak to us today. To introduce our speaker, I'm going to invite up the Division Chair and Director of the Kidney Transplant Program, Dr. Gupta, to give some introductory remarks. Dr. Gupta?
Thank you, Christian, and thank you for those who are here in person, and thank you for those who are listening on Zoom. It's my pleasure to introduce Dr. Ambreen Azhar to you. She is an assistant professor of medicine in the Division of Nephrology and Department of Internal Medicine. She's been here with us for 3 years, and prior to that, she completed her medical training in Pakistan, subsequently followed by fellowship in nephrology in Mount Sinai in New York, and then further transplant training and a master's in epidemiology in University of Tennessee at Memphis. Since coming here, she's led a lot of our research efforts in viral infections and kidney transplantation, SARS coronavirus 2, BK virus, and CMV. She's made pretty significant progress on these topics with funding from industry as well as investigator-initiated trials. So today we look forward to her sharing some of the data with us. Thank you, Ambreen.
Thank you. So thank you so much for such a nice introduction. What I'm presenting today is COVID and kidney transplant. And I don't want you people to think that it's again COVID, because it's going to be a little different. It's related to COVID in the setting of kidney transplant that you guys may have not heard so many times before. I have some disclosures. I have received funding for my work related to COVID from ViraCore, and I've also received funding from some of my other research-related activities. I'll also use the term COVID instead of severe acute respiratory virus 2, because that's easy and I like it. And I'll try to simplify the transplant-related terms in this discussion. So what are we discussing today? So we are trying to understand that what happened in kidney transplant in COVID. And when so many people were dying from COVID, so why did we started transplanting these organs? And what did we learn from this process? And where are we going in the future from this learning? So why COVID is important? It's important because it was a third leading cause of death in last few years. And you know, in health setup, the leading cause of death is always important for all our patients, but it's especially important in kidney transplant population because number one, our patients' mortality is affected by the leading cause of death, and we have to be addressing that. And the second thing is that all our donor pool, mostly 90% of the cases, is coming from patients who are dying. So 90% of transplants in majority of the center, they are from cadaveric donors. So that's why it's one of the important cause that I'm discussing today. This is a revision of something you may have seen many times, but I'll just revise it. So COVID is a respiratory virus. It comes into the lungs. It infects the respiratory cells, which are alveolar cells and endothelial cells. And then these cells, they get agitated and they release a cytokine response to get the major inflammatory responses of the body over there. So later what happens is that when there is a mass inflammatory response, there is vasodilation, edema, thickening of the pulmonary interstitium, And damage to the endothelial cells cause activation of the coagulation cascade that causes microthrombi in the lungs. So this is how the transplant patients present. So in this study, they divided their presentation into 3 phases. We all know that patients in general population, they present with fever, other symptoms, but in transplant populations, what is interesting is that with the early phases of the pandemic, the fever was less intense and was as compared to the normal population. Also, leukopenia was very predominant in transplant population, and it was one of the markers that was determining the adverse outcomes in our transplant population. In the second phase, they have respiratory symptoms, shortness of breath, coughing, all of that. But here in transplant populations, diarrhea is one of the common symptoms, which we usually don't see in the non-transplant population. And then in the final phase, it is acute respiratory distress syndrome, shock, cardiac failure, and release of all the inflammatory markers that determine the outcomes in transplant population. This is something interesting because transplant population, these patients, they have found to shed the virus for a longer period of time. The study will tell you that 25% of the kidney transplant recipients, they were shedding active and non-active virus for more than 30 days. And another study, they found that they were shedding the virus for more than 63 days and maybe more than that. So why is it so relevant? So it's relevant because when they shed the virus for a longer period of time, there is a chances that virus can get mutations, and that can result in new strains. And also, it is also important in isolating these patients, which is still questionable because we don't know whether it's active or non-active, but it is something which is there in the transplant population. Another important thing is that the outcomes in transplant populations, they are relatively different from the general population because they have a prolonged course, higher viremia, increased frequency of hospitalization, higher co-infections, bacterial and fungal, increased morbidity and mortality. So this is an interesting study that we conducted initially in the first phase of the pandemic. And this was a multi-center consortium, which was called Stop COVID Investigator Consortium. And we had 68 hospitals from all over US. And we included the patients who were in intensive care units. And we wanted to see their outcomes in first 28 days and compare it with the general population. So these were very short-term outcomes in the first phase of the pandemic, but what we found is that in the first 28 days, the mortality was not different between the two groups. Other outcomes like the risk of mechanical ventilation, incidence of acute respiratory distress syndrome, vasopressor use, they were also similar in between the two groups. What was different was that patients with solid organ transplants, they had higher acute kidney injury requiring renal replacement therapy. And we'll see in the next few slides that acute kidney injury requiring renal replacement therapy, it's one of the factors that determines the worst clinical outcomes in long run. This is another meta-analysis that tells us both short-term and long-term outcomes, and it has almost 2.6 million patients from all over the world. And in this meta-analysis, where there were so many patients from all over the world, we found that actually the patients with solid organ transplants, they had 1.4 times higher mortality as compared to the non-solid organ transplant recipients. So what are the factors that are associated with worst clinical outcomes in this population? So advanced age, diabetic nephropathy, acute kidney injury, comorbid conditions like cardiovascular disease, active cancer, obesity, higher inflammatory markers, if they are presenting with worsening dyspnea, if they are male, with poor socioeconomic conditions, African-American race, they're all associated with worse outcome. But what was interesting was that withdrawing immunosuppressive drugs completely increased the mortality in the first phases of pandemic, and we learned it with time. So what happened to the transplant volume in this era? So we can clearly see that in the first phase of the pandemic, the transplant volumes were markedly reduced and they picked up later. And there were many reasons for that. Number one was that there were no hospital beds for doing these elective surgeries. There was no personal protective equipment available for so many patients. But there were two interesting reasons as well. One of that all the donors, the disease donors, most of them were coming from the patients who were dying from COVID. And the other one was that everybody had COVID in the community, like a lot of COVID. So most of the recipients, they were also COVID positive at that time. So this is an interesting survey that was published in 2021, where somebody wanted to ask the transplant center that what would they do if the recipient is tested positive for COVID and they have an organ offer. So majority of the centers said that they will decline it because if the patient is asymptomatic, even without documented prior infection, they will decline it, considering it a risk. 30% centers said that if the infection was diagnosed 30 days ago and currently the chest X-ray is normal, they would do it. And a few programs said that if the recipient is not vaccinated, they will inactivate the recipient. So there was a lot of ambiguity, no standard guidelines at that time. Then this is something different as well in transplant populations as compared to general, because when we give the vaccine to the general population, we know they mount a response, but in transplant population, the vaccines are less effective. And it depends on the immunosuppression. There's certain kind of immunosuppressive regimens, for example, belatacept. It is proven that if somebody's on belatacept, they are less likely to mount an immune response to a vaccine. And age also matters. So vaccine response for adolescents was better as compared to older people. And there were no side effects of vaccines. So safety was equal in both the populations. So this is what is different from the treatment standpoint. And I'm not going into the previous phases of pandemic. This is what we are doing right now. If somebody is tested for COVID and they are asymptomatic, we don't admit the patients and we treat them with remdesivir. So here the transplant is different from non-transplant population because we see that Paxlovid is a medicine which is a lot more being used for non-transplant setup. It can be used in transplant population, but it has interactions with one of our major component of immunosuppressive regimen, which is called tacrolimus. So we are less likely using that. The study shows that if we treat somebody who is in the community with remdesivir, there's a less risk of hospitalization. And if some transplant patients, they do have symptoms and they need hospitalization, even then we treat them with remdesivir. And gradually we taper off their immunosuppression in a protocol, which is beyond the domain of this discussion. So this is something new, and this is also special for immunocompromised patients. It is just approved in April 2024 from FDA. It's called Pemgarda. It's a monoclonal antibody. It's similar to Avushil that was introduced a year ago. It attaches to the spike protein of the virus. It prevents the entry of the virus. It's given as a single dose, and it can be repeated every 3 months. It is only approved for immunocompromised patients. It does not have any drug interactions because it is not metabolized by the cytochrome and it's not excreted by the kidney. So it is safe for our kidney transplant patients. So another thing is that we can use this in people who are not exposed to COVID, who do not have COVID currently. We can only use in those people who cannot get vaccine and they need some protection. For example, if we are doing a fresh kidney transplant, and we all know when we were giving them thymoglobulin for induction, they're less likely to mount an immune response. And in that setting, we can use this one-time antibody infusion to give them protection against COVID. However, in those people who can get the vaccine, it will not replace the need for vaccination. And Avushil was something similar to this. It was introduced some time ago, but then later the research found that it is no more effective against the recent strain of COVID. That's why we stopped using it. Okay, so this was all about what was happening to our transplant recipients. So what else was happening in this time? So on one side, you see that there were almost more than 1 million people dying from this virus. And on the other side, this is recent data for 2024, we are still having 89,000 patients sitting on the list waiting for the kidneys. So it means that if more than 1 million people died, we should have 2 million kidneys available, minus some ESRD patients. And on the other hand, 89,000 patients are still waiting for organs. So there's always demand and supply disparity in the transplant world. I'm talking about kidney. There's so many organs, patients waiting for the other organs as well. And in simple terms, I would call it as poor recycling for organs that was observed in this era. So why did it happen? So we wanted to understand it in a little bit detail. And then we started working on this. And this was the first study that we did in this era. This was early utilization of kidneys from COVID positive donors. And theoretically, we looked into the data available and we found that COVID is a respiratory virus. It comes into the lungs like all other respiratory viruses. It damages the lungs. It can get resolved. It can cause damage, or it can completely go away. But it's less likely that COVID causes viremia, spreads to non-lung organ and infects them like other respiratory viruses, theoretically. So in our study, we found that between 2020 and 2021, what happened was that there was less awareness of this information and there was pandemic all over. So what people were doing, according to this study, was that they were procuring the kidneys from diseased people and they were discarding them. On the other hand, they were procuring organs, other non-kidney organs. They were not actually procuring the other non-kidney organs, like lung, heart, and intestines. So kidneys were procured and then discarded. And when we looked into it, a higher quality of kidneys, they were discarded. So we use this KDPI. This is a formula to measure the quality of the kidneys. And we found that higher quality of kidneys, they were discarded at that time. Another interesting fact was that the organ discard rate did not differ if the dying person had COVID 7 days before death or a month before death. If they had COVID, they just discarded the kidneys. And this is something else that was happening at that time all over the world. So we can see that the first case of the coronavirus was detected in January 2020. And first liver transplant was done in July. And this liver transplant was done from somebody who was incidental positive for the virus and did not have any symptoms. And that was also positive like way back before this transplant surgery. Then somebody did a kidney and heart together in 2020, and up until now, there were no guidelines. And you can see that with the passage of time, there were more phases, a Delta phase, Omicron phase, and people started doing kidney, pancreas, lung, and up until now, there is no bowel transplant from COVID positive donors. And I'll discuss it why. So then American Society of Transplantation, they published the recommendations that what to do in this situation when most of the donors are COVID positive, most of the potential recipients, they are positive testing for the virus. So they said that there is unclear risk of transmission. It's not clear because we don't have data, but there were 4 cases where they tried to procure the lungs from patients who died from COVID. And they did only the upper respiratory swab. And 3 of them had possible or probable transmission, and 1 of the lung was not used. But no transmission was reported for kidney transplants. So then they included in their policy that we have to do NAT testing from a respiratory sample, which could be any respiratory sample for a non-lung transplant. But for the lung transplant, it is must to have a lower respiratory tract sample. And ideally, we should test the donor 72 hours before procurement because it minimizes the risk of unrecognized infection. So some centers, like we found out in our study, that some centers are also looking into other things like CT value. So CT value is something we all may know that it tells us that how many cycles does the virus need to get amplified and be detected. If the cycles are low, it means the virus is in the higher quantity and is more transmissible. Also, centers were also looking into the donor information like prior history of COVID, vaccination history, how severe was the COVID at that time, and all of that. So how did people were started to select the recipients? So we started doing kidney transplant from COVID positive donor here at this place in early 2021. And what we did was that we made sure that our recipients were vaccinated according to the protocol, and they had willingness to accept any future treatments like prophylaxis or any other therapy that is required after transplant. The recipients should not have active symptoms at the time of transplant. And some centers said that they didn't even care of that, and they just wanted the willingness of the recipient to accept an organ from COVID positive donor. An interesting case report was from a liver transplant done in a recipient where the organ was coming from somebody who had active COVID infection with respiratory findings, and they did transplant the liver and there was no transmission reported of the virus. So this was something else. Like up until now, you all know people are doing transplants. We are just saying that theoretically the virus cannot be transmitted through the blood. It's a respiratory virus, but there is no evidence right now, no solid evidence in real. So we started this study, which is called Detection of Transmissible Acute Respiratory Virus. And what we did is that we used a research test which could detect the viral PCR in the tissue and in the plasma. This was not approved for general population, it was a research test. So what we did is that we transplanted the organs coming from the COVID positive donors into COVID negative recipients. And at the time of transplant, we did their organ biopsy, the kidney biopsy, and we sent it for testing for PCR. And also we sent their blood samples for PCR testing at the time of transplant and later after the transplant. And we did not find any viable virus in the tissue and the blood coming from these donors. So there was zero transmission detected in this study. And that was the study that could help in utilizing these organs with a solid evidence in the future. There were some other interesting findings that we found. This was a very small population of patients, but it was a good data to start with something. Another thing that we found was like 3 of our recipients, they developed the infection after the transplant, but they developed the infection in that window where it could not be labeled as a donor-derived COVID transmission. Also, we had access to their mate organs, and we knew that the mate organs was fine. They were fine, so it's not coming from the donor. And all of them, all 3 recipients, they kept their organs. Their viral infection was not severe, and they are all doing well at this time. And there is some interesting data which you will see in this table is that in this small population of patients, we found a higher rate of rejection. You can see that we found rejection like almost in 8%, 12% of the cases, which was not our baseline percentage in our center, but we wanted to have like higher patient population to validate this. So there are so many findings that we found in this study that we wanted to see what's happening all over the US. So we created a COVID donor consortium where we reached out to all the centers in US that were doing these kind of transplants, and we collected the data from them, and we created a consortium. This is the first paper from our consortium. We are doing the 6-month outcomes after this transplant. And this is a multi-center prospective study. We did propensity score matching. We matched our special recipients who received the organs from COVID positive donors to the recipients who did not receive the organ from COVID positive donors. And we found that mortality was not different. There was no transmission detected. And the something which was really special that we found in this was that there are 2 kinds of donors who have COVID. One of them who have COVID and they don't have findings in their lungs. They don't die from COVID. They are incidental COVID positive. The other people are those who really died from COVID and its complications. So we found that 6 months eGFR was relatively lower in those recipients who received the organs from the donor where the direct cause of death was COVID, as compared to those recipients who received the kidney from those donors where COVID was an incidental finding. So this was interesting, but it is just 6-month outcomes. We have to publish our long-term outcomes. And this got great appreciation. Like this was selected as one of the best ASN manuscripts in the ASN journals. And then we got a patient to write an editorial for us because he went through the same situation where he was COVID positive and he was declined to get a kidney, and he really appreciated our work, and it was a really great positive editorial. So this was something which was greatly appreciated by both the transplant community and the patient population. So what we learned through all this journey, a little bit pathophysiology, but this is important to understand for our future work. So we all know this is a virus. This is an RNA virus and it has 4 proteins, E, S, M, and N protein. The most important protein is spike protein because spike protein is used for entry and spike protein binds to a receptor, which is called ACE2 receptor. And spike protein is a trimer and it is the binding site for that receptor. So the receptor is called ACE2 receptor. And when I was a student, I used to think that ACE2 receptor is only present in the lungs. But then I understood with this, like you see the rainbow at the bottom of this figure, that ACE2 receptor is highest in the colon, and then in the heart, and then in the lungs, and then in the kidneys. So it is present on the podocytes, on the epithelial cells, on the brush border of proximal tubular epithelial cells, and also glomerular epithelial cells. So it is present everywhere in the human body, and theoretically, the virus can attack this receptor and enter into any organ in human body. So what are affecting the interaction between the antigen and the receptor? So you know that we were using antibodies at some time to inhibit the entry. They inhibit the entry of the virus and they bind to the receptor. The antibodies that are created by vaccination also, they inhibit the entry of the virus. But there are some comorbid conditions that promote the entry of the virus. For example, if there's a higher systemic inflammatory cytokine response, they will modulate the receptor on both ends, and they will promote the entry of the virus. And also you have seen that everybody's saying that there is higher mortality in old people, people with comorbid conditions. So why is that? Because those conditions, we have studies that have shown that those conditions, they modify the receptor and it promotes the binding and entry of the receptor in these conditions. So this might be something new for you, angiotensin 1 receptor antibodies, but it's a common term in transplant world. And I'll tell you what is it. So angiotensin 1 receptor antibody is an antibody that binds to a receptor, and which is for angiotensinogen 2. And this antibody binds to the receptor of angiotensinogen 2 and blocks the action of angiotensinogen 2. In the transplant world, this antibody is considered to be bad because it causes rejection. This is how in the human body the homeostasis is maintained. So we all know that there is renin, angiotensin 1, and angiotensin 2. And there is a homeostasis system in the human body where in normal situation, 81R and 82R are kind of balanced. 81R causes vasoconstriction, inflammation, oxidative stress, all the bad things, and 82R causes all the opposite things. So the question was that if the antibody is stopping the pathway going towards 81R, which is the bad pathway, vasoconstriction pathway, so could they be protective in kidney transplant in the setting of COVID? This is again, we are showing here that how there is an imbalance in these two systems. And angiotensinogen 2, if that part of the cycle is activated, we'll have more vasoconstriction, fibrosis, and oxidative stress as compared to the other pathway. And you know that the virus is blocking the ACE2. So if we block the ACE2, all the angiotensin system will go towards the 81R and will cause this RAS imbalance. But this is an interesting study which tells us that the study tells us that angiotensin 1 receptor antibodies, they were increased in patients with COVID infection. So these antibody titers were increased, and also the virus was blocking ACE2 receptor. So think about it like in this diagram, if the virus is blocking ACE2 from one side and the antibody is blocking the 81R receptor from the other side, where will this angiotensin 2 go? So it will create a refractory immune state where it will go nowhere and there'll be less immune cytokine response, and this should theoretically have a good prognosis. On the other hand, some people said that if you block these both pathways, this angiotensin 2 could be converted into some other forms of angiotensin which bind to 81R receptors and actually causes vasodilation, less inflammation, and a protective response. So it is still questionable that whether these antibodies that are more in patients with COVID-19 will be protected which are usually considered as bad in the transplant world. Also, this is something interesting that when patients died in COVID and we had autopsy studies available, even though we are saying that viable virus was not detected in the organs, these autopsy studies showed us that there was dead virus and messenger RNA present in the kidney tissue at that time. And what could be the implications of this in the current scenario? Because is it possible that this non-viable proteins and inactive DNA in the kidney could serve as a vaccine? Because you know how we make the vaccines. We make the vaccines from inactivated proteins and messenger RNA, and we are giving them the kidneys which may have dead particles, RNAs. So it was still unknown by that time. So we created this clinical trial. We started it and we included small number of patient population, 20 participants. And what we did, we wanted to understand their immune responses before putting in the organ and after putting in the organ to understand what's happening in them. We wanted to compare them with those transplant recipients who are not getting organs from COVID positive donors. It is still in process. We have some interesting results here. In the beginning, we are checking both T-cell immune response and antibody-mediated immune response. This is a very prelim data that is coming from this study. And this is for T-cell immune response against COVID. So all our recipients had a T-cell immune response before putting in the organ. And 23% of these recipients, they lost the T-cell specific immune response against the virus, only 23%. After the kidney transplant. And this response was checked at 1 month. And one of them had a transplant from COVID positive donor and rest were from non-COVID donors. But the antibody mediated response is still pending and the final results of the study are still in the process. Also, there's something interesting that you saw that in our small cohort of 26 patients, we found a higher risk of rejection, but then in our consortium, we only found 2% risk of rejection. And then there was an initial hypothesis that there's a high risk of rejection because we were giving less immunosuppression to these patients because initial phase of the pandemic, we are not sure. So we were deviating a little bit, most centers were deviating a little bit from their standard protocols. But then in long run, when we collected the data from all over the US, we found that the rejection risk was not different. And this is also something interesting, which we all know that COVID virus can cause proteinuria. And we are choosing the kidneys from these donors who were tested positive for COVID, and some of them died from COVID. So what are the causes of proteinuria in these individuals? Number one is acute kidney injury. COVID virus causes acute kidney injury, which can cause proteinuria. We all know that. However, if a donor is African-American ancestry and they have an APOL1 gene, that this virus and the inflammation in the kidney can trigger a pathway which causes a distinctive entity which is called COVID-associated nephropathy and nephrotic range proteinuria. And then if somebody has CKD, they can also progress and they can see worsening of proteinuria. So the message here was that if we are choosing the donor and they are African-American and they can have this FSGS, so we need to see them carefully because sometimes the focal biopsy can miss these changes. This is another lab study which showed that they created organoids, and organoids are those cells that you are creating from pluripotent human cells in the lab, and then you can convert them into any kind of cells. So they created kidney organoids and they infected them with the virus, and they showed that cells that were infected with the virus had more fibrogenic pathways. They had more fibrosis as compared to the no other cells. This was coming from this pathophysiology because the virus infected the cells and virus triggered the fibrotic pathways, TGF, PDF, all the fibrotic cytokine markers that led to fibrosis. But this study was limited to the lab. It was not a human body study, and there were so many other interactions that we have to see in the human body. So I think our long-term consortium can give us the answers about this specific finding in real transplant world. So I think up until now, we understand that understanding the organ tissue science, especially when you're doing a cadaveric kidney transplant, it's very important. because it affects the clinical outcomes. And you can see a lot of complications. You can foresee them and you can treat them accordingly and you can improve the outcomes. So this knowledge forms the foundation of one of our new projects at Humvee Transplant Institute, which is called DD study. This is called Deceased Donor Kidney Transplant Study. And you know that up until now, we are relying on KDPI calculations. We are relying on indirect evidence coming from here and there, from animal science, from lab science about what will happen to this organ. But this is a multi-center project where we are trying to create a point of care tool that will be used at the time of kidney transplant using molecular assays. These molecular assays, they tell us the changes one step before they come to histopathology. So the whole purpose is that we should have a tool that can predict the graft function, that can tell more about this graft before we are putting the organ into the human body. And it can help us a lot, like it can give us a direct evidence and we can improve the clinical outcomes based on this. So this is something very preliminary that just came from this consortium. So we have the set of genes that tell us about injury and senescence of the organs. So we found that when we are relying on KDPI and on the wedge biopsies of the kidney, they are never perfect. And they don't tell us what's going to happen. And it is proven through different kind of research done in the past. With this study, we found that the injury genes, the set of injury genes or injury classifiers, they tell you the 7-day outcome or the risk of delayed graft function as compared to you relying on donor age and KDPI. So this was the first step, but this very beginning, we just showed our 7-day outcome. This study is going to go for a long run and will tell us the long-term outcomes as well. So here I will end my presentation. Thank you so much. And this is my email for any future queries and collaborations. Thank you so much.
You can start with any questions here in the audience.
Great talk, thank you. Really enjoyed that. What are your injury markers? What are your molecular markers, and how did you decide on those particular ones?
So we are collaborating with a lab which is in University of Alberta, and they are working on it in the post-transplant setting. So we are already using this marker in the post-transplant setup. They're basically divided into two groups. One is the marker of aging, senescence, and the other one is a marker of injury. So they are all those genes at RNA level. They are transitioned to the RNA level, and we divided them into two classes, those genes that are determining aging and those ones that are telling injury. And I can send you the details because there are a lot of genes here. So this will tell us the longevity through senescence and DGF, which is delayed graft function, through the injury markers. Yeah, I can send you the details.
Do you think your measures of senescence will be better than just age? I think you're measuring biological senescence with those transcripts.
Yeah, that's what we showed, that donor age, sometimes you get a 70-year-old donor, but when you see these markers, they could be like younger than 70 years, yeah.
Great presentation. Thank you, Dr. Azhar. Was wondering, initially when COVID came out and we were looking at the data that came out from Wuhan, the Chinese papers and other papers suggested there was higher propensity of proteinuria, almost as high as 40%, and hematuria was almost 20-30%. So when you, or kidney patients were selected in this case, were we looking at proteinuria and hematuria even?
Yeah. So we, hematuria.
Could you repeat the question briefly?
Yeah. So Dr. Fatani has asked the question that there were initial reports that COVID can cause hematuria and proteinuria in patients infected with COVID in general population. So when we were doing this transplant, did we look into these outcomes as well or not? So we did look into proteinuria, and we did, hematuria was not a labeled like clinical outcome, but we didn't find any significant difference in proteinuria. I couldn't show that slide over here, but we have it available. It's a published article. And in the consortium as well, we didn't find any difference in proteinuria.
I wonder, because you said the GFR is lower in the COVID transplanted kidneys that are there.
Yeah.
I wonder if there's something.
I think that's more about fibrosis, I think. But we'll see how it shows like in the future, because a lot of these patients, they had biopsies, and we have not included biopsies right now at this time of the publication, but when we will publish the long-term outcomes, we'll show up the biopsies as well.
And they had more. or-
Yeah, based on my clinical observation, in some patients, we did see fibrosis, yeah, and we switched them to belatacept, yeah.
Any other questions here? The audience? I have a general question. You mentioned remdesivir in your current transplant patients that are diagnosed with COVID-19. I'm sure they're all instructed to call you all when they have symptoms or they test positive. We have a lot of people in the audience who work in general medical settings or inpatient hospital, or have family members, other people in the community. What would you advise a transplant patient who is out in the community who gets diagnosed with COVID? Contact you all. Does it matter whether they are 3 months within the transplant, 6 months, 10 years? Do you have any comments on that?
Okay, so at this time, we are recommending all our transplants patient to call us or connect with us if they are tested positive for COVID. If they are asymptomatic, we just monitor them at home. If they are far away from transplant, which means like more than 1 year away from transplant. However, if they are asymptomatic and they are fresh within a year, sometimes we still treat them depending on their overall immune status. If they have symptoms, then most of the times we need to admit them. You don't need to admit them, like if they have mild to moderate symptoms, we can give remdesivir in the home hospital setup if that's possible. But if they have severe symptoms, we need to admit them, monitor them, modify their immunosuppression, and go from there. So transplant is in a way that we have a coordinator, so they are in touch with all our patients, and most of our patients, they do tell us when they are tested positive or when they have these symptoms. So in general, like if anybody is testing positive, I think they should inform their provider. Even if they are asymptomatic, we keep them on our watch list. And if they have any symptoms, they can always get back to us on this.
As an ICU doc, the thing that struck me in talking to colleagues at other centers is how COVID has decimated the renal transplant population as far as mortality. But the data you presented didn't strike me as much as being that, the mortality being as high as what my clinical experience is.
Yeah, so I show in this presentation, I showed 2 types of data. One was the short-term outcomes and then the long-term outcomes. So in the short-term outcomes, and that was also from the first phase of the pandemic, they saw that in critically ill patients, they were the same, and they were from 68 hospitals across the US. And in long-term outcomes, we did see that the mortality rate was 1.4 times higher, but that's what data shows. And the long-term outcomes, they were 2.6 million people across the world. So
What's the estimate of the number of people with a kidney transplant who actually died from COVID over the past 3 years?
over the past 3 years, I don't have the exact number, maybe Dr.
4 years.
So I think I also don't know the numbers for the overall mortality for kidney transplant across the nation or across the world. What you observed is what we also observed. Our observed mortality for kidney transplant we see was much higher than was reported in the published news. I think a few things stand out for our population, which are not as much as true as across the world or even the nation. There was a racial distribution in terms of mortality. And 2/3 of our patients are Black Americans, which probably also played a role. The other part, which was also highlighted in the published study, was that indigent population suffered more from mortality, which is another point that we see here. So I think more so than COVID, it is really the distribution of patients that we serve that's at play here in terms of outcomes.
Thank you.
There's one question online from Dr. Mayer over at the VA. Have renin and aldosterone levels been tested in patients infected with COVID? Are there differences in infection rates in patients who have primary hypoaldosteronism
I'm not aware of,
comments?
yeah, I'm not aware of this particular issue tested in this population, but as I said, that we have seen that there was a tendency towards angiotensinogen 2 binding to 81R when somebody is infected with COVID. So this is something which can be tested retrospectively if we can, but I am not aware of anything that was tested in the past specific to this concern, yeah.
Any other comments, questions?